Hey there, and welcome to Connect the Dots Learning Center podcast. I'm Stephanie Wagers, your host, and I'm so glad you're here. Whether you're a seasoned therapist, clinic owner, or just starting out, this podcast is your go to spot for insights, tips, and stories that'll help you connect the dots in your practice. I'm chatting with Lynn Tanner, a pediatric physical therapist, researcher, and the CEO and founder of YourSteps Health. She is also the scientific director of physical medicine at Children's Minnesota. So yes, she wears a lot of hats. YourSteps recently won the APTA Pediatrics Practice Fair Innovation Award and is also a 2025 World Summit Award nominee. But what I love most about Lynn's work is how grounded it is in real families and real clinical care. Lynn talks about her early work with children undergoing cancer treatment and how it opened her eyes to patterns she just couldn't ignore. Families were doing their best, but so much of therapy depended on what happened at home, and the systems around them weren't designed to support that reality. That disconnect became the spark of everything she built since. We talk about generic home programs and why they fail flat, how to think differently about dosage, and how technology like remote therapeutic monitoring can actually strengthen the therapist-family partnership instead of replacing it. We also zoom out and talk about where pediatric therapy is heading and what we need to do better if we want our work to be understood and valued. If you care about parent engagement, better outcomes, and making therapy more doable for families, you're really going to enjoy this conversation. Yeah, I just want to walk through kind of your journey a little bit. And because I know your journey has kind of shown you these repeating patterns, which made you develop your steps health. Is that right?
That's true. This is very
Okay.
true. Yeah.
Okay.
So I am a pediatric physical therapist who started in hospital-based outpatient, right? General outpatient. So I was really fortunate. So 24 years ago now, I was fortunate to work in a large department. So physical, occupational, and speech therapists with all different ranges of experience. And I loved it. I mean, I think, the ability to help each child and family reach their goals is a gift that I still see today.
Yeah.
And I always remember that, right? Because sometimes minutes are hard. Sometimes some days are hard, but the gift of being able to help a child and family is there's nothing like it. So I loved that from the beginning. And within, I was really lucky because the second year of my career, I met a 4-year-old with acute lymphoblastic leukemia. That's the most common type of cancer. And his mom. And his mom was like, okay, I kind of had to fight my way here to get a physical therapy referral because I was told that this was going to get better. My child is walking differently. I know it was caused by treatment. I know it, and it's not getting better. And I'm just wondering, can we do something about it? And she was just one of those parents who had all those questions and was determined to get answers.
Hmm.
And uh, I did what I always, he was toe walking and from chemotherapy. And I knew like, okay, we can do something about toe walking, both
Right.
in physical therapy and occupational therapy, right? We work together with our
Right.
families. But what I didn't understand at that time is kind of what cancer and chemotherapy had to do with it.
Yeah.
Um, so that led me down this path. I ended up, I said I would never do research. Ha. But
Never
because
say never. It bites you. Yes.
that started there, because this parent had so many questions, and when I looked into the research, there really wasn't answers. There was very little research in rehab in children with cancer. At that time, less than 10% of kids were getting any type of services,
Hmm.
and we just didn't know. And so we started a physical therapy program for children with cancer, and that now has occupational therapy and speech therapy involved as well.
Amazing.
Yeah, it's so
Amazing.
fun. And
Yeah.
thankfully, because of this mom, she connected me to a nurse practitioner in oncology who connected me to a researcher in oncology. And that researcher said, you have to collect data. Because she said, you're doing something new. And the only way that that we can learn and do better is if we look at data. And we can talk about that, but because, right, I was a therapist, just loved seeing
Right.
kids, was like, I don't want to do research, but I have
Yes.
such a greater understanding now of, yes, but how many therapists complain about insurance reimbursement,
I
complain
know.
about referrals, complain. You know how we get that reimbursement and how we get those referrals is if we show what we do works. And
Right. We're
so,
horrible at that.
right,
Horrible.
right, we are. And the thing
Yeah.
is you don't have to do it alone. You just
Right.
you can work with a researcher. You can, right, there are, or you can even just say, hey, I just want to keep treating kids, but I have this question that I think we need to look at.
Hmm.
And find somebody who wants to research it. Because I think that's how all of these are frustrations. That's how we're going to make gains towards
Right.
overcoming frustrations.
Right.
Um, anyway, so that led me into research. So I then was a clinician researcher. I actually didn't go back and get my PhD until much later on, but I
Okay.
partnered with people as a clinician. So
Okay.
I was seeing
That's
patients.
reassuring right there because I think, people don't want to go back to school and all of the research stuff can be boring. And I
Mhm,
think it takes like a certain type of brain to really enjoy that stuff. So
mhm.
that is really reassuring that
Yeah.
you don't have to have your PhD to
No,
do that.
no, no. And the best research teams always have a clinician, a treating
Mhm.
clinician as part of them. I really believe that. Um, and so I had kind of really, so we started this program, we started seeing more and more kids with cancer. Well, I saw kids with of many diagnoses, but I ended up creating my own job because
Okay.
you see the problems, right? Like
Right.
families really were struggling to make different appointments, right? So they were
Okay.
canceling, they were not calling to reschedule, things like that. And
Mhm.
I knew, the families, it wasn't that the families didn't want the services. I think that's a often, right?
Yeah.
They want it. It's
Yes.
just hard. And
Well, they
so
have a lot going on, especially
they,
a family with a child with cancer.
right? Right?
Yeah.
I mean, right? There's so many things they need to do. They need
Mhm.
to work. Their kids need to go to school. They need daycare for their other kids, right? There's so many things.
Mhm.
And so I created my own job so that I could treat kids in the cancer clinic. I could do research and I could also be an operational leader to grow the
Okay.
cancer rehab program. So
Okay.
then I got to, I got to then have kind of all of it meshed together. And that gave me experience, right? I met with the medical director of oncology. I met with the COO of the hospital. I met with, right? I got to all in the aims to getting kids access uh,
Mhm.
with better outcomes. So
Mhm.
that was quite the journey. There was
Yeah.
lots of, sometimes we are like, ugh, why can't this happen? There were scheduling issues and, ugh.
So tell
But
me a little bit about so you kind of created a system to help families get access to care, like easier, right? So
easier.
what did that look like? Was that your telerehab program or was this something different?
Oh, so that came along later. Yes.
Okay.
So first it was, okay, we're going to provide, we had, I believe, as far as I know, the first rehab gym built in a
Mhm.
cancer clinic in the United
Okay.
States. So that was the first thing we did, right? We wanted a space. Although I believe rehab, we can do things in a hallway if we need to. So I
Yes.
don't let that be an excuse. But
Right.
um, and then we built the systems. So then it was, how do these families schedule?
Okay.
Who is making their appointments?
Uh-huh.
How can we coordinate appointments? So we
Right.
worked on that, right? And that then we started having better access.
So
However,
let's stop there for just a second because I know a lot of practices struggle with parents making appointments. So what was the conclusion? What was your
yeah.
workaround there?
Yeah, no. So what we did is, because I was specifically here now in cancer rehab, and I knew, so you have to look at the population and look what the
Yeah.
families are facing every day.
Hmm.
And the families were like, well, we come to the cancer clinic once a week. Can't we just get it here? And so what we
Yeah.
did is we're like, okay, their clinic assistant at front for the cancer clinic was making the appointments for the chemo infusions, for the
Hmm.
provider visits. So we're like, well, why don't they just make the rehab visits too?
Hmm.
So we did.
Simple.
So the, they, the clinic assistants got to know a lot about rehab,
Yeah.
and, it took some time, right? But
Hmm.
that way for the family. So we fixed our systems on the healthcare side.
Hmm.
So we made it doable for the families.
Awesome. And that's where we're falling apart.
It is.
Yes. Yes.
We can do this. Families want it. We have to figure out how to make it accessible and doable
Yes.
for families. And that has kind of continued throughout. So that made access better there in
Hmm.
cancer.
Hmm.
But then all that led to I was looking at the outcomes and seeing kids, and the families were of course sharing their frustrations
Hmm.
consistently, right? Year after year after year. And I
Hmm.
had families, because I had families that lived, less than a mile from than the clinic, and then I had families that lived 3 hours away
Right.
because they were coming to a regional center, right? So and I had families of infants, and I had families, we treat young adults. So I had young adult patients, and hearing how the differences there too, right?
Hmm.
And the families all, you know, struggled and how they do things at home. They knew
Right.
it was important. They could say,
Hmm.
I know this is important.
Hmm.
Um, but how do I do it in the everyday? How do I know what to do today? What I did last week and what I can quit and what I need to
Yeah.
work on now that's new. Um, and so that continued to be, I knew in therapy, we think about dosage,
Hmm.
right?
Hmm.
So and it's the same as like in medicine, right? At medicine, you need a certain dose of the
Right.
medicine to make it work. It's the same thing with rehab. You need a certain dose to make
Right.
it work. Well, what's important, so that dose is visits. So they need access
Hmm.
to their visits, but the biggest dose is really what they do at home,
Yes.
right? That's the biggest dose.
Yeah.
And so and it's so funny because in research, so I started like delving into the research
Hmm.
about what do we know about how much families are able to do at home. And I gotta tell you, it's really frustrating when you look for that research because it's really hard to find.
It is. And I will tell you, because that's what I looked at for my program too. It
Oh
it
yeah,
is, yeah, just like
we don't know.
we
We
don't
don't
know.
know. We
Mm-mm.
don't know. And a lot of it has to do with how we collect that data, and that I can
Hmm.
go into the research nerdiness of that. But families, a lot of times they're supposed to fill out a log, like a diary, and then they're supposed to hand it in. And it just doesn't work well. And we know
Right.
that, but we keep
Yeah,
doing it. And
I know.
because it's the only way. They're starting to do some cool things with texting and stuff like that. So there's more now with technology.
Yeah.
And so we know that dosage is what get outcomes. We also know, but we don't know how much families are doing it. And that's the important thing too, that I think I learned along the way. Every family is different compared to
Hmm.
that. That's what I
Hmm.
loved.
Yeah.
We as a therapist, and I know I've seen what you've talked about, and I so believe this. It is part of our skill
Yes.
to learn to meet a family, get to know them, get to know kind of how they work, and then personalize that program for
Hmm.
that individual child and family. It
Yeah.
can't be the same. It can't be the same. It's
It's not
not
what we
like
want
no.
or
And it
what
can't.
the research says it should be, right?
And so often we want to make it like, okay, 30 minutes of exercise at this level for
Yeah.
this much every single day.
Yeah.
Okay. But then that could be like, I had a patient that loved skateboarding. And so we made a whole home program
Yeah.
with a skateboard.
Right.
Everything he needed to do was on that skateboard. I learned a lot about skateboarding.
Yeah.
Or for a mom with a dad with 3 young kids who are leaving the house by 6:30 every day
Ooh,
and getting home at 6. Okay, what does it look like for
right.
that? I think the cool thing is in what we do in rehab is there's so many options. There's
Hmm.
so many options to
Hmm.
get, whether you're,
It's about being
strengthening.
creative, right? It's
Yes, it's so
creativity and asking the parent questions about their life so you can tailor it.
yeah, it's so fun.
Yeah.
And with our background and training, right, as we're not just trained in play, we know the neurological system, we know the
Right.
musculoskeletal system, we know, I know a lot of information about cancer drugs and how it impacts the
Mhm.
body. We can integrate that information then
Yes.
within the creativity and the human connection with families and put that
Hmm.
together for a home program.
Yeah.
I think that's part
Yeah.
of the skill. So I don't think it's on the family. I have to say this. I don't think it's
I
on
100% agree with you.
the
I
family.
would say if they didn't do the home program, you didn't get it right.
Thank you.
Yeah. I look at it like we're cooking for this family. So we need to decide what do they like to eat. And then we're going to design a recipe that meets their nutrition needs, if they have any allergies, right? And
Yeah.
then, but every family is going to look different. They're going to have a different recipe. So
Yep.
this cookie cutter, like I hate handouts. Sometimes just hand out, hand out, hand
Yep.
out.
Yep.
Yeah.
Yep. And I think yeah, I mean, the research I do is based on a protocol for kids with leukemia. So there is a protocol, right? Like
Hmm.
there is,
Hmm.
this is the assessments we use. So we
Hmm.
measure our
Yeah.
outcomes,
Yeah.
and that's really important. But the cool thing is it allows tailoring
Mhm.
of the type of exercise we do. So we know our categories. Like I know that kids on a certain type of treatment, it causes vestibular imbalance changes. Okay, so I know that I have to do some balance dosing for each child.
Right.
And I think it's important to bring our skill. So the skill gives the foundations of as you say, the recipe, right? So we know
Mhm.
from research, we know from our education in the musculoskeletal system, in the neurological system, in the integumentary system, in understanding pharmacology. We know, right, the different parts of the recipe that is needed.
Right.
And if we don't know it, we're learning. That's what the research is
Yep.
for, right?
Hmm.
So maybe they have neurological damage to their nerves from chemotherapy.
Hmm.
Therefore, I need strengthening, I need balance training. Okay, so those are the recipe components. Now, part of the recipe components is this individual child and family. And what are their goals? Family-centered care. What are
Yes.
their goals? What is important to them? What do they like to do? What is their day-to-day routine? How do the different members of their family interact, right? So you
Mhm.
take that, you take your creativity and you put it together um, for a program for that individual
Yeah.
family,
Yeah.
right? But the thing is in talking to families over time, I was maybe handing them. It was a one-way
Yeah.
communication. I was
Right.
giving I was giving them a handout, you
Hmm.
know, or even I used apps. I tried different apps.
Yeah.
Putting a program on an app, and then they would come back, right? In a week or a month, and I would say, "Oh, how's it going?" I
Mhm.
tried to do the partnership.
Yeah.
However, it was kind of typically I got a vague answer, like, "Oh, it's going okay. We're doing some
Hmm.
things, not other things."
Hmm.
Or, "Oh, it's really hard to fit in the day." Or, "Oh, we're doing really well." Right? And then
Yeah.
you would assess the thing. Let's say it's
Right.
just a thing. I'm just gonna pull something, and you'd be like,
Are you
we
really doing it? Yeah.
haven't made a lot of gains. And so I think I was really looking for something that could improve partnership, because that's
Hmm.
that's what I knew, what I
Yeah.
thought from learning from all these families was going to improve partnership. They're doing most of the work at home. So
Yes.
how can I
Yeah.
best
We're what?
help them?
1 hour a week,
Yeah.
maybe max. Yeah.
Yeah. Yeah. I always tell my families from early on, I don't have magic hands.
No.
I could maybe, yes, facilitate something and it happens 1 or 2 times. But the thing is that then we need it to happen 100 times, right? At
Right.
home for the child to be able to feel confident and to do
Yes.
it on their own.
Yeah.
So how do we do that? So my story, my parents, uh, were really into technology. So they wrote
Okay.
textbooks on how to use technology in education. So I was
Oh,
kind of surrounded by it,
okay.
right? My entire career or my life from being a kid. And so I was always interested in technology. And so in our research and in our clinical care, I would bring new technologies in. I was always the person who went to a conference and I never missed a course. And then I would go down into the expo hall and I wouldn't just get the giveaways. I would like actually learn about the technologies because I don't know, I
Yeah.
think they're so interesting. And I had used a lot of technologies that companies were made for adults, and companies said,
Mhm.
"Oh, you can
You
use
can
this
do it
for
in peds.
you. We have Pete's content. See right here."
Yeah.
And um, as I looked into the research on that, research says, guess what? Kids don't use adult tools, and we know it. And I'm kind of like, we know this. We know
Yeah.
this. It's so established. Kids don't use adult tools. So,
Mhm.
and I also knew I got frustrated with companies that I'd worked with them for years. One company, 18 years. And they told me they were going to put pediatric norms into the technology. And
Mhm.
18 years later, when I bought it, and 18 years later, it's not
Right.
there. And so, and honestly, now I can kind of understand why. They only have so much money, they only have so much
Yeah.
resources to put into their product. And so
Mhm.
they really have to use their money to help their customers who,
Mhm.
if it's mostly adults, then that's where they're going to put their resources. I mean,
Right.
it's not,
Yeah.
it's not intentional, right? It's just
No.
done. And
And
so
they don't live it. We live it.
yes,
So it's in our face all the time. Yeah.
yes.
Yeah.
So I was like, well, okay. I tried a couple things. I even tried a kids app and I gave them a whole bunch of exercises that didn't
Uh-huh.
work. So then we decided to make it on our own. So
And
yeah,
that's
so
what First Steps is, right?
Your Steps is. Yep, Your
Yours.
Steps designed by we had 10 kids and families help
Okay.
design it. So they
Okay.
have their fingerprints all over it. So everything from colors of things
Mm-hmm.
to they have a lot of opinions about the rewards they get.
Uh-huh.
Um,
Yeah. Well, it matters, right?
it matters. And the parents really care. And the parents are different in what they want out of apps.
Mm-hmm.
So that was importance for Your Steps that we make it. The parents can pick and choose some things within Your Steps
Oh, nice.
so they can personalize it to their parenting style.
Yeah.
Um, and so all of those things then, make it what it is today that
Mm-hmm.
and we still there's so many things we can do to continue to make it better as we grow. But
So it's
um
an app, but it's also remote therapeutic monitoring, right?
yes, yes,
Okay.
yes.
So
So I'm gonna take
let's talk about
it.
that piece a little bit because in pediatrics, this is a very new thing. I think it's been going around for adults for a while and very much embraced in that setting. But I know it's still kind of like, are they going to pay for it? Are they not going to pay for it? And there's really strong stipulations of what you have to document about. It can't just be random things.
Nope,
Yeah.
can't be anything. No. So, yes. So Your Steps is FDA listed as a
Okay.
medical device, which then so that is one requirement you have to have is it has to
Okay.
be a medical device defined by the FDA
Okay.
to be able to bill for remote therapeutic monitoring. And what remote therapeutic monitoring is it's monitoring of non-physiological data. Okay, so
Okay.
so physiological could be your heart rate,
Hmm.
your right, maybe the glucose monitors. That's
Hmm.
what you hear as like remote patient monitoring.
Okay.
Remote therapeutic monitoring is non-physiological. So it can be patient-reported outcomes, exercise adherence, things like that, right? In rehab. And PTs, OTs, and speech therapists can bill it. But right now, the codes are built for musculoskeletal and respiratory diagnoses. So that's also
Okay.
a requirement. And the codes started in CMS approved them, so Medicare in 2022.
Okay.
And it's growing because new codes that are making it easier to use are approved for 2026. So we're
Okay.
going that direction. So
Right.
please, pediatric therapists, let's not take, typical for us, I'm sorry, is that
Yeah.
we lag way behind adults
Right.
in innovation. So let's jump on this faster this time because what it's made for is to improve that partnership between bring clinic to home, right? So improving that data exchange that is coming from the home to help you as a therapist better design that plan of care for that family.
Right. So you mentioned new codes are coming. What do those codes look like?
Yeah. So the present codes, there's the first code 98975 that is for you putting them on a platform.
Okay.
So a medical device that and instructing them in how to use it. Okay.
Okay. And that's billed one time.
That's built one time, and that until up to this year, you needed 16 days before you could bill it. Okay. So, and that's to prevent things like, let's say I'm just seeing a patient one time, I shouldn't be able to bill that code, right? So,
Right.
so
So they're an ongoing patient. You need to be showing that they're an ongoing
there's
patient.
an ongoing patient,
Okay.
right? So now so it used to be you couldn't bill that until after day 16. Now in 2026, you can bill it after 2 days.
Okay.
So that's what I'm saying is like the payers are actually trying to help us here and make it easy.
But
right?
what about, so it's very musculoskeletal based or respiratory, which is not the general of what most outpatient peds do.
It depends.
So
So physical therapy vary.
physical therapy, yes.
Most of our kids will often in musculoskeletal. And I think, yes, I do think we need to grow in like neuro, right?
Yes.
Diagnoses. And there's some work there. If you, I think this, again, as is typical, this started in adult care. Well, what is the biggest population? Adult musculoskeletal. So it started there. So we will get there. I think the idea is, and the payers, and I've talked to a number of payers, they're very excited about the fact that, oh, you'll be able to know what's going well and what's not going well at home. That will only improve their outcomes.
Right. And they're going to have to pay less money, which they're going to love.
And don't worry, therapists, because therapists will be like, well, then they're going to take our jobs. Okay, so this is not, I need everyone to know that the access to care is so poor for pediatrics. There are so many kids out there. And a study I did that is published, 51% of kids who were referred to PTOT and speech in general outpatient care did not get that first visit. So there are so many kids that need our help. There are so many kids that need our help that aren't getting it. And so this is part of it. This is part of it. How do we use our time as specialists? How do we best use our time to help as many kids as possible? Right. So this is part of it. So
and we're still going to have to prescribe what's happening. So it can't take our jobs. Yeah.
No, so don't worry. It will help you. The way I think of it is redistribution of visits. So now I know, okay, this kid and this family is doing well, and I only have to see them once a month. And they really, like, because of the child, because of the impairment, because of our goals, they're really doing well at home. And I can see that. I can see that in the data that I get with a one-click report. So I can see that kid isn't going to need too many visits. However, this kid over here in my world, let's say their function really changes with chemotherapy doses.
Mhm.
Okay, this kid is like a roller coaster going up and down, and I can see it. And so, okay, this kid needs more visits. So it actually helps us to know who needs what when,
Right.
right? And so it's
Yeah.
not, it doesn't take your job. And by the way, I will say if that's what you're worried about, you need to remember why you got in this for what you got into this for. Most of us will say we wanted to help kids and families. We
Mhm.
didn't say we want to help therapists.
Right.
The thing is that there's so much we can do as therapists. We have so many talents that I am not worried about technology taking our job. We will always be needed. We
Mhm.
will just be working in slightly different ways. And we will, I think we will always be seeing people in person or telehealth
Right.
but we will do what that individual family needs, what that works
Mhm.
best for that family through technology, right? Or
Mhm.
through in person. Anyway, I can go along that path. But
Yeah.
back to the codes. So the codes then, the second set of codes is how many days a month is data exchanged. So
Okay.
it used to be up until 2026, it used to be 16 days of data per month needed to be exchanged.
Okay.
Now, for you to bill a code.
Okay.
Now, in 2026, that goes to 10 days.
Okay.
So you can bill a code between 10 and 15. Oh, I'm sorry.
And when
No,
you say
I'm wrong. I'm
exchange,
wrong. It goes 2 days. I apologize. 2 days.
2 days?
2 days. 2 days.
Okay.
2 days to 15 days is a code.
Okay. So that means you've prescribed the exercises. Parent logs on, it says what they did. That's 1 day, right?
Mhm.
You coming back and tailoring anything. Is that two, or the parent needs to come back?
Every
Any?
any data. So
Okay.
if there are and data that you're acting on, right? So if I said, let's say I'm seeing a kid once a month,
Mhm.
and because they live 3 hours away, so guess what? And they don't have a pediatric therapist in their area. Guess what?
Right.
Okay, all right. Okay, so I prescribed your thing. I look a week later and look at, oh, you're doing your balance exercises, your single leg stance on the app is getting better. Your sit to stand, though, isn't getting better as fast.
Right.
And okay, but I see that you're in the app 4 times a day. I can get that number with one click. Okay, so
Mhm.
that's I have 4 days of data exchange, right? So I
Mhm.
so if I wanted to, I could build that code in 2026. Now, I'll wait because I'm seeing the month isn't done and I think you're going to do more than that. So if we go back and forth, I look a week later, now, this is getting better, this isn't. I adjust something a little. I keep track of my minutes that I'm doing that,
Mhm.
right? Um, and so at the end of the month, within a month's time, there's one set of codes that looks in how many days of data were exchanged. Okay.
Mhm.
So that's one set of codes. So I have
Okay.
that. Then there's the management codes, which this is the time-based codes that therapists
Mhm.
are very used to. So
Right.
how many minutes did I spend looking at their data and interacting with them? Um, if it's over 10 minutes in 2026, I can now bill a code for that. And
Okay.
that includes one synchronous, so at the same time, audio interaction. So
Okay.
could be a phone call, me saying, hey, I noticed that their 6-minute walk is getting better on the app. I love that you're doing exercises 4 times a week. Tell me about the balance because the balance isn't getting better.
Right.
And it looks tell me what's going well and what's not going well at home, right? I might talk to them on the phone about that because I'm not seeing them for 2 more weeks,
Yeah. Right.
right? So all those minutes then, right? You keep track of
Mhm.
those in the technology. So in YourSteps, you keep track of that and it'll add up for you. And
Okay.
at the end of the month, depending on if you're above 10 minutes, you can bill a code.
Okay. Huh. And does it integrate into your EMR or no? Are they separate?
They're separate right now.
Okay.
We do, it is on our roadmap to integrate with EMR, and we want to do it smartly. So we're in the learning phase right now.
Mhm.
We've the research on technology is that you have to learn from people who use it first
Yeah. Sit back and watch a little, right?
before you design it. That's why we designed it with kids and families first. So the
Mhm.
same thing with us integrating into electronic health records is we
Mhm.
need to see how therapists are using it first and really then design the integration smartly. And
Mhm.
because otherwise it's going to be clunky and you're not going to use it because you're going to be like, ugh, I have to push this button and that goes that and then right. So
Right.
ease of use is really important. That's what we call it in technology. How easy is it to use? And we know right now with our platform that our therapists currently using it, 100% of them say it's easy to use.
Mhm.
And we put a lot into that. There's buttons on certain pages to make it super easy, right?
Mhm. And is it a desktop app or iPhone
Yeah,
or?
yeah, for it could be accessed either way. I would highly
Okay.
recommend a desktop though. It's on a browser.
Yes.
Use a browser,
Okay.
any browser. But technology develop is really important, how people use it to if a button is at the top or the bottom of the page, okay,
Mhm.
or what color it is, or
Mhm.
the workflows, right, of how you use it. You want less clicks, okay?
Right.
So we have that built and we feel like, we're doing pretty well there. And also I would say to this remote therapeutic monitoring concept, 100% of our therapists on the platform right now say they believe this is an acceptable way to deliver healthcare. And that's us
Mhm.
saying,
Yeah.
right? It's a hybrid. You're in person and asynchronous care, right?
Yeah.
So, or telehealth or by virtual visits.
Mhm.
That's synchronous telehealth, right? Uh, so I think we're going the right direction, but yes, we
Mhm.
want to do it smartly. So it's the way therapists use an EHR, not maybe
Yes.
the way a different healthcare professional uses the EHR.
Right. So what would a clinic have to have in place for this to be effective?
Sure,
What kind of
sure.
tools do they need?
What kind of tools they need? They need computers, right?
Yeah. Everybody should
So
have a computer.
everybody should have a computer, and it works best if they have a laptop that they can bring into session.
Okay.
Okay. Now, I know that's scary to therapists. It's okay, right? People are getting
Yeah.
used to laptops being in session. You're not going to be behind it the entire time. You'll at the end, you'll go, okay, this went, I love this went really, this session was
Mhm.
really great. We learned this and this. So let's talk about what you're going to do at home. Let's get it
Right.
into your app. You'll sit down and say, okay, I'm thinking that 5 times a week for this routine will work.
Mhm.
Um,
Mhm.
do you think that'll work for you? And the family will say, I think that should work. I mean, Wednesdays and Saturdays are really busy for us though. And oh, okay. Let me
Mhm.
fix that in the app right here. Not
Yeah.
Wednesday, not Saturday. So see how that computer in your session helps
Yeah.
you connect to your family. They're
Mhm.
giving you their schedule and you're telling them back, oh, okay, I'm going to put that into the app right here. And so they can see how it's valuable to their care.
Mhm.
Okay. So you need
Okay.
a computer. Um, and then you need a license agreement with us, right? A license agreement. We love legal agreements, right? No, you need you need a
Well, you
subscription.
have to. Yeah.
You have to. So you need a therapist subscription to use the platform, and you get to use it with as many patients as you want.
Okay. And is
So
it
that's
per therapist you pay or per patient?
per therapist. Per
Okay.
therapist.
Okay.
That may change sometime in the future. But
Mhm.
I really feel that's what we're all accustomed to right now in pediatrics.
Mhm.
And so that feels really fair to me as we're just getting used to a new type of service.
Yeah. And is there an onboarding fee? Like, do you do a one-time purchase app fee and then Pay
That's a
subscription?
very good question. Just a subscription.
Okay.
If you, depending on, there is online training. There's lots of modules and
Okay.
resources. I know some people like videos, some people like
Yeah.
handouts, so quick guides. So those are both available.
Okay.
If clinics want more, they can pay an onboarding fee for more virtual training,
Mhm.
um, more hands-on virtual training throughout. It's not. It just
What
depends.
kind of, yeah, what kind of clinics are using your platform currently?
Yeah. So right now, we have anywhere from a small community clinic to we have a
Mhm.
large pediatric healthcare system, starting at the beginning of 2026. And then I have solo. So I have cash-based therapists using it. I have
Okay.
therapists who have their own LLCs that are using it. So and I have a school
Oh,
system that is using it in early intervention. And they actually,
interesting.
the way they're using it is, oh, it's so cool. They're using it with their teachers and their paras, and it's pretty fun. So again, that collaboration,
Right.
who is involved, to help this child meet their rehab goals.
Interesting. So with a cash-based practice, they're not billing insurance. So how's that working? Are they billing the
No,
patient for it
they,
then, or?
they, no, that is their decision. And honestly, I don't go, that is not my decision.
Yeah.
That is
Okay.
not
So
my
it's
decision.
just they're utilizing the app.
They're utilizing the app.
Okay.
And so
Gotcha.
the way they figure that out on their side is up to them. I mean, I have to say the cash-based world is totally new to me. I am on the insurance reimbursement model, always have been. So the cash-based care is new to me. It's growing in some areas though because of access
It,
issues.
it is growing, and I get why it's growing because, reimbursement is so low and the hoops that they're making you jump through just cost from the
Uh,
visit that you're getting,
yeah,
right?
yeah.
When you
So
have to touch it 17 times before they
yeah.
even get in the door. Yeah.
Exactly. So, I mean, I think our healthcare systems are
Mhm.
changing. And if
Mhm.
we always remember, why are we doing this? We're doing this to help the child and family. If we always remember that,
Mhm.
uh, then I think we need to think differently and
Yeah.
listen to our families and how they want the care.
And if someone wanted to talk with you more about it, would they go to, how do they find you?
Yes. So they can go to our website and there's a, like a contact us, which is
Okay.
yourstepshealth.com. Or they can email me if
Okay.
they want. My email is Lynn, Lynn Tanner, Tanner, at yourstepshealth.com.
Mhm.
They can email me as well.
Awesome.
So
And I'll put all of that in the show notes too, so people can grab it if they're driving and they're trying to frantically write it down. So,
yeah.
one kind of last question for you: where do you see the pediatric therapy industry moving in the next 5 to 10 years? And what do we need to do to change to adapt to that?
I think we need to do better at promoting our profession and the skill we provide.
Hmm.
Um, and I'm doing that through looking at, I'm also still a researcher, right? So I will be presenting data on how physical therapy impacts survival from childhood cancer.
Hmm.
And the reason I give that as is we need to show that what we do in rehab impacts, so we know it, right? It impacts, let's say,
Yeah.
a child with autism and their ability to get a job when they're older.
Hmm.
We know that, right? But we don't communicate that well.
Hmm.
And so we need to show our outcomes through research. We need to um, speak. Here's the thing. I'll give the example. A physical
Yeah.
therapist will say, I'll hear a physical therapist talking to a physician, and they'll say, "Oh yeah, I help kids move." Hmm. Okay, I can tell you that I, as a PT, have been called a gym teacher on the cancer
Oh,
floor.
yeah.
Now, I love gym teachers, so it's not that, but my skill
Yeah.
is different, right? Um, and so I think we need to do better at saying, yeah, I understand the nervous system. I know that vincristine causes microtubule damage to the nerves, which then changes the way a child walks, um, which they then have contractures over time, which likely then leads to back pain as an adult
Right.
and leads to them being less physically active, which then leads to an increased risk of cancer in the future.
Mm,
Okay, so do you
right.
see how that is
Oh, yeah.
different than me saying, yeah, I'm a pediatric PT and I help kids move?
We need to be able to take our clinical reasoning that lives in our head only and be able to spread that message of why are we thinking this way and what is it going to do?
Yeah.
And that is not what we're doing.
That is not what we do. That is not what we
Yeah.
do. And
Yeah.
I think we also, I will say, think that other healthcare providers understand what we do. And I have to tell you, it's not their fault that if they don't. They
No,
weren't educated. They weren't educated as
right.
what does a physical therapist, what does an occupational therapist, what does a speech therapist do? Especially they weren't educated as what do they do when they're kids? Like
Oh
when
my
you
gosh. Yes.
like when you say, oh, a speech therapist works on swallowing and a baby in the NICU. What? Speech therapist? What? Right? Or
Yep.
understanding the difference between in the United States, how we provide medically based rehab services, and then we have school-based rehab services.
Hmm.
They weren't told that the difference. So we need to educate not only our families, but we also need to educate other healthcare providers. I love working with people with all different perspective and skill sets.
No.
And when we work together, we provide the best outcomes, right? So that's why I teach a continuing ed course on cancer rehab. I don't just teach it to PTs, OTs, and speech therapists. I teach it to physicians, pharmacists, researchers,
Yeah.
all together at one time
Hmm.
because we all need to learn together, right? So I think that goes into how we communicate what we do. That went into another research study I did, and families said, well, I wasn't going to pay the deductible of $500 so I could watch my kid play with a therapist. You
It
know,
drives me crazy. I know. But it's our fault. It's
I
our fault.
know. We need to educate. We need
Yeah.
to seek research.
Yeah.
And we need, like, I gotta tell you, like my families, the families I work with, I said, we learned from our research in physical therapy in kids with leukemia that kids are stronger more than 5 years after cancer treatment is done if they had PT in the first year. Like,
Yeah.
and the families will go, really?
Oh,
And then
you
they'll
got
go,
me. Yeah.
oh, that's really, we need to do this,
Yeah.
right?
Anything in the works for you? This is a lot, but do you have anything else under the rug?
So I really want to really keep learning from
Hmm.
therapists and learning from families about how we make it better uh,
Hmm.
for them. I'm an international speaker, so I love teaching.
Yeah.
I'm a keynote this year at the International Conference of Oncology Physical Therapy.
Wow.
So I get to teach on the benefits of rehab in pediatric PT, and so I will be doing that. I love teaching others and then teaching and learning. I would say teaching
Yeah.
and learning about what pediatric rehab can do. So I'm going to continue that and continue research because. So YourSteps is actually also on some research grants. So I'm not just making this up that this is
Right.
going to work. We're gonna really learn how it works, who it works for,
Yeah.
how therapists use it to make it work the best way.
Mhm.
Um, I believe in research.
Yeah.
And
Well, yeah, you've inspired me, and I hope that the listeners have been inspired to like get in there and just do the research. You don't have to analyze the data, but you can just be the
nope,
clinician in it.
you
If we
can
want to
be part
continue
of a
therapy,
research
we got to
team.
show it. Yeah.
Yeah, be a part of a research team. You don't have to do all the things. They can do the things. But
Yeah.
if you're interested, you can learn. You can learn how to do
Right.
the things. But
Yeah.
your voice and families' voices are really needed in research to make it impactful. So
Well, thank you, Lynn. It's been so fun chatting with you today. I will
yeah,
put all of your information in the show notes.
thank you.
Anything else that you want to share?
No, I just keep doing what you're doing. I
Thank you.
think kids are our future, and I
Yeah.
think that they deserve our attention.
Yes.